Okay. Okay. Jayanta, I will take that question separately. Senior, please make a note of that. We will address that.
Oh, sure.
All right. Okay. So good afternoon, everyone. I'll get started. Today's session is about laying the foundation for good practice. And I will say that some of you who are already adept at this might find some of these things to be information and knowledge that you already have, in which case I apologize, but I will also then ask you to perhaps, step up and help me maybe explain it a little bit better to the people to whom these are new concepts. So some of you are already working in the field. Some of you have extensive knowledge with working with cancer patients, even if it is not in palliative care. So I will ask you to please raise your hand or maybe ask to speak, and we can bring you in for specific examples that you might find sharing with the rest of the batch is useful. So I'm just going to share my screen. Hang on. We're doing a very broad strokes kind of thing here. Here, I would just like to sort of introduce most people to the idea of what it is that we're looking at as a fundamental foundational aspects when we enter into a relationship with the families that we take care of. When you encounter a patient or a family for the first time, you are meeting them at a very vulnerable time in their lives. They're not well. They are emotionally, socially, financially threatened in many ways. And how we are able to help them or assist them largely depends on the relationship that we form with them. And so what I want to really share with you today are some tools and some perspectives through which we try and build this relationship, so that not only do we earn their trust, but we also get the information that we need to help them in the best way that we can. Okay, so first of all, let me just recount what we talked about last week, which is that total pain is the fact that the physical pain or distress reported by a patient is compounded by their life circumstances. We all agree that that is true. And how people's, social life or their family life is derailed by the disease also has a huge part to play in how much distress they're in. And there's something like a social diagnosis. We need to also understand how this disease or this illness has actually affected the person socially and in the situation that they are in. And for that, we have some very practical tips that we can, practical ways of assessing what exactly the extent of that social damage or social impact is. Okay, so my question to all of you here is, now we know about total pain, we know about all of that, but I want you to step out of that box and perhaps in your own words, tell me why you think psychosocial care is so important in palliative care. Why is psychosocial care so important? I would say it's at par with medical and physical care. But why? Why is psychosocial care important in palliative care? So please use the chat box. And if you like, you can unmute yourselves and very briefly talk to us about what it is that you think makes psychosocial care so important in palliative care. Okay.
The medicine is also very important content, and as well as that, the social environment, like psychological situation, everything need to be taken. All are connected.
Yes, but why? My question, you've described what, but tell me why. They are connected, yes, but can you elaborate a little bit more, Anne? By paying attention to psychosocial aspects, how will that help me as a clinician? Anybody. This is open to everybody. Okay. Some of you have said mental well-being of a patient and caretaker are required. Yes. Because we can know more about patients, every detail. Yes, Nivedita, but why is that important for us to know? Why is it important for us to know every detail? Yes, please, Saptik. You're muted. I can't hear. You're not muted, but can't hear you.
To ease up the recovery of the patient, to ease the recovery of the patient.
All right. Okay. Saptik, you want to try again?
Hello, ma'am.
Hi.
Yes, ma'am, because our medical system is currently based on the biopsychosocial model. That's why we can't depend only on medical model, biomedical model. Currently, we are focusing on biopsychosocial model.
Okay, fine. But do you think that happens everywhere? I mean, although that is the ideal model, but do you think that happens enough for everywhere?
No, ma'am.
Yeah.
There is another model that is called health belief model. That is very different according to the demography, economic perspective. So it cannot be followed everywhere.
Okay. All right. Thank you all very much for your inputs. And I can see there are more inputs in the chat box. It will help in understanding needs, patients, setting their affairs in order. Very important point. So we can provide more support to that patient. It doesn't happen everywhere. Okay, fine. Now, by really going into the psychosocial aspect of a person's life, we start to piece together the story of their life. And what do they think their story is? How has this disease impacted or derailed that story or changed it? And what do they wish their story looked like? So you can look at the facts. Like there's a saying, like facts are the bones, but it's the stories that really flesh out the whole picture. So if you look at just the facts, if you go just by investigative numbers, if you just go by tests and so on and so forth, yes, you get a sense of what that person's disease looks like. You don't know what that person is like as a person, right? So this is where the psychosocial aspect comes in. And very quickly, I'm just going to go into this. Now, living with a life-limiting or life-threatening illness, or the awareness of approaching death, causes very unique stressors and challenges that you will not find in any other situation. If you are just going through life, you're healthy, all of that, the challenges you face are very different from those who are living with a life-limiting, life-threatening, or a terminal condition. Okay. Now, if you were to know, just very simply now, cut all your current scenarios, wherever you are, whichever part of the country, whatever your economic or family life is like, if you were to be given a diagnosis of a life-limiting or life-threatening condition, what's going to change for you? You don't have to share it with a larger group. I just want you to reflect on that question. What would change for you if right now you were presented with a life-threatening diagnosis? What will change in terms of your approach? What becomes a priority? What stops being a priority? You're welcome to share if you like, but really this is a personal reflection that I want you to sit with. Everything changes, okay?
Number one, the hope on longevity changes.
Yeah.
And urge to settle something at home will changes. Priorities will change.
Yeah.
And they need some support in case they can't handle their family events.
So I'm asking you to think about it from your perspective. So you're going to need, yes.
The hope will change and the priorities will change, And if based on my illness, if it is prolongs for some time, or does it terminate very quickly, based on that, mm, whatever I can do for the family, that will be done
Okay.
according.
Okay, so that's a good scenario that you've painted for us. Now you've said so many things have changed. Various people have said other things have changed. How important would it be for your healthcare provider to know what your priorities are? Because if, say, it's they tell you that you have to move into the hospital or go into you need to have a full-time nurse, or you need various whatever, so many changes to your diet, very expensive medication. How much of your story is important in this? For how much would you like your healthcare providers to know about you, so that you can work on this together to arrive at interventions that you are, one, able to afford, are of good quality, and are within the means and bounds of what you as a person are capable of. So my question here is, how important would it be for you that your healthcare provider knows about your priorities, as you have listed just now for me? Everybody who has responded has said that your priorities will change. Yeah.
So it is very important to let the professional know about my priorities. There is a one, so that I can get how much help I can get from the professional. And if it is unbearable, I can get the volunteers or some support from the external sources with the help of somebody. So
Great.
for me, it is important.
Okay. If I were to ask all of you on a scale of 1 to 5, 5 being extremely important, 1 being not important, I don't need my healthcare provider to know, what number would you give me?
5.
5. Yeah.
5.
Yeah. Can I see more responses in the chat box, please? Yeah. 6. Yep. So we all agree. Let's say we all agree, more or less. Now, what happens if my healthcare provider is not interested in knowing that? And they don't give you an opening to have that conversation. So you've all said it's really important. You've all said your priorities will change. You all said your healthcare providers should ideally know. But now I'm your healthcare provider. I really don't care. I'm just going to give you the medication. These are my interventions. I'm great at what I do. My results speak for it. So I don't want to know about your backstory. I don't have time. You may not change the provider. Some of you, someone has said change provider, but you may not, because they're the best in the field. But how will it leave you feeling? How will you feel?
I will feel more hopelessness.
Hmm.
So I feel very depressed, saying that nobody is there to listen my story. And that's all.
Thank you.
I share it with my family members. So
Thank
they
you.
have to listen.
Great. So I think you've
Or
spoken.
maybe, ma'am, sorry.
Yes, please, Anukriti, go on.
Yeah. Or maybe we trusted blindly to our healthcare provider, that
So
he must be good in his inexperience.
you're saying maybe we should trust him blindly?
Yes.
Okay. What if you're not allowed to ask any questions? You'd be okay with that?
No, maybe I'll, after some time, maybe I make a good rapport with him. So can I ask a question?
Yeah, but some providers don't allow for that to happen. They have the EQ of a teaspoon, but that may not happen where they even allow that conversation to take place.
Then I'll look for the result. If I am looking, if I'll be now okay for his or her treatment, then I'll be trusted him.
Very high stakes game you're playing there, Anukriti, where you're using your body as as where you're going to decide whether it's worth your trust or not. Anyway, but it's a complex.
Okay.
See, there's no right or wrong answer. It's a very complex thing, and we all live in India, right? You get a forget a life-threatening, life-limiting diagnosis. You get a flu. you'll have 10 people telling you what to do, including your cousin's friend who's a doctor, right? Or somebody else who knows someone who has an opinion and they've seen a lot of stuff on Google. We do not, so it's a very complicated relationship that people have with the healthcare system. Sometimes the best of doctors don't have the time to have these conversations. Sometimes they do. But all in all, here I'm not trying to get you to judge our healthcare system. I'm asking you purely from your personal perspective. If you are diagnosed with a life-limiting, life-threatening disease, what changes? Many of you have said a lot of priorities will change. How important is it for those priorities to be part of your goals of care? Important. And what happens if the person who's providing that care to you does not talk to you about those things? Then you end up feeling, you're not going to feel good about it. Okay, you might go along with it for a while, but certainly you're not going to feel good about it. So that's why we talk about psychosocial care being important. Also, a serious illness will disrupt individuals' thoughts and feelings, relationships, social and spiritual supports, financial stability, and spirituality. So not only is there a reprioritizing, there is also a disruption of various aspects of a person's life for which a person will need support and help to navigate this time. Okay. Now, can somebody volunteer, somebody who hasn't spoken yet, volunteer to please read this slide out? Somebody who's feeling sleepy, maybe? Great way to wake up.
55-year-old lady diagnosed with diagnosis of cancer.
There's a terrible sentence. Oh, yes. Please go
on. Mucosa has been referred to you after receiving radiotherapy and chemotherapy at the Regional Cancer Center from 2021 onwards. She's accompanied by her husband and son. She's in pain, emaciated, nauseated. All three people appear emotionally low and distressed.
Okay. So I'm just going to give you a second. That first sentence is terrible grammar, sorry. So just give you a couple of seconds to really absorb the story. We have a woman who's 55 years old. She has diagnosis of cancer of the buccal mucosa. She's been sick from 2021. And she is accompanied by her husband and son. She's physically not well. She's in pain. She's lost all her body weight and mass. She's nauseated all the time. And everyone appears to be quite distressed. So where will you start? What part of this story are you going to dig into to start with? This is a snapshot that you receive. Now, this is typically this is the first impression you have, yeah? Where do you start? Anyone? No right or wrong answers. Just let me know where you think you would like to start. Okay. Okay. So, Geeta says, ask the husband and son about details of care. Okay. Saliha also says with the caretaker. Okay. Anyone else?
Ma'am, they need a cancer education, like we give in our education for every disease. They need to understand the progress, the medication, the how long it may take, and the most important, they need how to be patient. They need patience to increase their patience with all the education part.
Okay. Saptik, you are on the right track, but before we go to educating them, we need to make sure that we know what they know, right? Don't go straight into education mode because they are the experts. They've been running around regional cancer hospitals since 2021. They may be fully over-educated about cancer for all you know. Yeah? But you're right about the information part. You're absolutely right about that. Information is absolutely key. Okay, Shivakumar says, understand the family and respect the emotions running. How would you demonstrate respect? When you say respect the emotions running, how would you demonstrate that you have respect for their emotions? Just sit with that. We will be talking about that in the communications class. But I want you to please be mindful of, when we use certain phrases, let's try and get more granular. Yeah, we know all this stuff about psychoeducation, empathy, respect. But I want you to, when you talk to me here, I want you to try and tell me what that means for you and how you're going to be able to demonstrate it. Okay. Strengthening the bystanders and kindle hope. Again, see, these are broad strokes. Tell me how you're going to do that. Create an atmosphere of reassurance is a good way. It's an excellent point. Empathize, listen, excellent. Ask them what happened and let them talk so we can understand. Excellent. Okay, so we're getting more and more granular. All right. So this is really important because the more we practice this, the better we get at it. Early in my career, we would use these broad terms like allow them to ventilate their feelings. Great term. What does that mean? What does ventilate feelings mean? Are people just going to come and pour their hearts out to you just because you show up in the room and ask them to? No. Okay, so let's be mindful of what our actions convey. Let's try and steer clear of the jargon. All right. Okay. So, all right. So we're not going to try and resolve this family's problem right now. So we've all talked about where we would start. Let me now talk to you a little bit about assessment techniques. Now, firstly, we need to understand that when we talk about assessment, it is an exploration process. Exploration means we need to go in with curiosity, with humility, and not assume that we know better than them. We are here to explore. When you go into a new city for the first time as a tourist, you might have done your homework and your research, but to really get to know that place, you have to really walk through it. Okay. And you might have some landmarks of, hey, I heard this restaurant is good, or this is a great tourist spot. But the actual experience is very different from what you read, right? There's also another saying, the territory is not the map. The map is not the territory. So you might have read all these people's reports earlier. You might have their file. But to really know what they're about, treat it as an exploration and allow them to take the reins. These are people from whom control has been taken away. Okay, by allowing someone to tell their story, you're handing over some control back to them. And that is one way of showing respect, by the way. The selection of goals and interventions depends largely on what is being assessed. So this is when I say what is being assessed, I've underlined it. That means we have to be very clear in our heads which part of the story we're going to focus on, depending on what we think is a priority as expressed by them. Okay, now, if you just go in and say, tell me about your journey. First of all, as a patient or as a caregiver, I'm not going to know where to start. I need you to help me figure out a starting point. Okay. And when you decide what is being assessed, then we also get a little bit more focused about how we're going to assist these people to find solutions to their problems or to manage their distress better. So assessment is a process of exploration. It requires curiosity, humility, and a sense of being open to whatever it is you're about to receive. We often go in with preconceived notions that the person is scared of losing hope. The person does not want to know their diagnosis. No, every single person is different. Okay. And if the assessment is inaccurate or incomplete, it'll end up with inappropriate goals and interventions. So inaccurate and incomplete assessment will, without fail, lead to inappropriate goals and interventions. So we have to be very mindful that where we're starting is really, really important in determining where it is we're going to end up. Okay, the aim of assessment is to identify factors and interventions that may influence the overall well-being of the patient and the family. So we are looking at the total pain matrix, where we say there's physical pain, socioeconomic, emotional, spiritual. Now we have to find out where in these different areas are they hurting? And there are some ways in which we can do it. I'm just going by what we try to do at Pallium India. And we also have to remember, some of you said that you would start with a caregiver. That's a very important point. But there are various sources of information when we're trying to do this exploration process. The patient and the caregiver are, of course, the most obvious. But then there are also collateral sources like friends, relatives, neighbors, and a home visit, like what I said in our first session. A home visit can tell you so much about the needs and requirements of a family. Okay. And from time to time, especially if somebody is in your care for a longer period of time, and there's a lot of like, psychosocial complexities, that's when collateral sources like friends, relatives, and neighbors do become important in corroborating what it is that we need to do. And I'll come to that in just a moment. Now, the other thing I want to just mention very quickly is assessment is an ongoing process. It is not a one-time process. And because as the journey unfolds, the psychosocial needs of patients and family caregivers will change over the course of the illness. Now, there's a diagnosis, right? Suddenly, you are still healthy-ish, you're not feeling sick, you have a diagnosis, and suddenly this is like a big, warning to you. So quickly, you're trying to get your finances in order, et cetera, et cetera. You're going to try and get organized in terms of, how are we going to pay for treatment? What are we going to do? Which is the treatment option, et cetera. As the disease progresses, as the illness progresses, you might have some what we call breakpoint events where you might lose mobility, or you might lose the ability to look after yourself. You might lose the ability to your independence. You might lose the ability to drive, to be independent of other people. You might lose your job and therefore become financially dependent. The family as a whole might suffer financially, right? So important decisions in relocation of reallocation of resources. Okay, this person was going to go to college abroad, not going to happen now because we need that money to be rerouted here for some sort of treatment. So as these things happen, the changes also result in the psychosocial needs changing. And therefore, this assessment is an ongoing process, and you have to keep walking with them through this entire process. So what is really important in all of this is every interaction with your patients and families requires purposeful observations and purposeful conversations. Okay, so it's not this rambling conversation about tell me your emotions, tell me how you feel. Be very, very specific in, at least in directing the conversation to a certain extent. We're not trying to control the narrative. We're saying, okay, tell me about like a doctor would go in and say, okay, last time you were in pain, we gave you this medication. How is your pain now? What is happening is that's a very purposeful sort of conversation. So then depending on what the patient's symptom control looks like, medication will be tweaked. Similarly, for psychosocial assessments, we're going in to say, okay, fine, what are your needs? What is troubling you? What is bothering you the most? And we had this, I've shared this on a different platform. We actually, I remember this time when I was very, very young in palliative care in general, but also in Pallium India. And one of the first few times I went on a home visit, I went with Dr. Raj and the home care team. And we actually were directed by the local, the volunteers to a fisherman's house somewhere in one of these outlying villages. And so we actually couldn't get to the house by van because it was not motorable. So we parked the van some ways off, maybe 400 meters away, and we walked towards the house. And at least 50 meters before we got to the house, we could hear him screaming in pain. And he was screaming so badly, so loudly. It was really, really painful to even hear. And when we got to the house, the whole house was stinking. It was like there was this terrible stench. And there was this very young lady, his wife, who was just standing there utterly helpless. The thing with him is that he had been discharged from the hospital. The family had been told there's nothing more we can do. Please take him home, keep him comfortable, and here's some medication. And they released him with a feeding tube. Now, in our culture, we also like to feed people, and we think that's a way of nourishing them, and that a patient, no matter what, if they're not even having their medicines, they at least have to have something to eat. Nobody has talked to this woman about the fact that in advanced stages, you may not have an appetite. But in this particular case, what the problem was that he had a bowel obstruction. And he was being fed whatever he was being fed. The bowel obstruction was actually causing him to regurgitate his waste. And so it was a terrible situation. So home care team stepped in, took care of him, and morphine was administered. But on the pain scale, he came from a 9 to a 6, and he got stuck at 6. And no matter how much pain management was given, he was stuck at 6. So I remember this very clearly because Dr. Raj at that point got everyone to step out of the room. I was still in the room, and he asked this fisherman, he said, "What is bothering you?" And to me, actually, it seemed like a pretty odd question because it was all pretty obvious as far as I was concerned. It took that man a very long time to respond. And that's the other thing. If somebody doesn't answer your question within 30 seconds, what are you going to do? What do you do if someone's not answering your question in the first 30 seconds? Get uncomfortable, ask a follow-up question, forget about it.
We can understand he can't express and he doesn't know what to say.
Yeah, so will you ask again or reframe the question? Repeat the question, someone says. Okay, Geeta says, all right. So here's the thing. He was asked a very, very simple question. What is bothering you? What's troubling you? And it took that man approximately 6 minutes to answer. But for 6 minutes, Dr. Raj didn't fidget. He sat with him. He sat with him quietly for 6 minutes. And it's not an easy thing to do, to sit in silence with another human being without the urge to say something, right? So after approximately 6 minutes, this fisherman said to us, he said, all I wanted was for my children not to be fishermen. That's what's bothering me. So he knew he was dying. His wife was not educated. He couldn't provide for the education of the kids. And his biggest worry in that moment was that his children were not going to go to school. They were going to be fishermen. And that gave us the answer, right? So anyway, next we have this program, this education support program for children. So usually, but it takes some time, like a few days to a week to get the school linked to us, etc. But we sort of sped up this particular case. And by the next day, we had some pledges. We had donors who were willing to support these two children's education through to college, etc. So we went back to the house with that. His pain was still at 6. Then we showed him all the paperwork. We told him the kids are going to go to college. He doesn't have to worry about the education. And then he was asked again what his pain was on the pain scale. And he said 1. So that is how total pain also works. This gentleman died about 3 days later, absolutely pain-free. So the reason we're telling you the story is also to demonstrate that this is why sitting with somebody, asking them about their priorities is really important, rather than us assuming what it is that they might need from us. Yeah. And anyway, coming back to this. Now, what are the, one second, move this out of the way. What are the important areas to be assessed from the point of view of total pain? This is like a quick sort of summary slide. We look at the patient and family overview. I will tell you what each of these means. Insight about diagnosis and prognosis, family structure, dynamics, socioeconomic conditions, psychological state, spiritual distress, psychosexual issues, interventions, and plan. So typically, these are the various aspects that we cover. But the most important, of course, the most basic stuff is the patient and family's basic demographic details, occupation before and after illness to tell us what was impacted in terms of occupation. Was the patient the breadwinner in the family, or was their income actually vital to the financial health of the family, and so on? Who is the primary caregiver and what is the relationship? Primary caregiver is not always the wife or the daughter or child. Very often, especially in our settings, it will be the youngest. It might be one of the daughters-in-law, and so maybe she does not really have a very strong relationship with the patient. She's the newest member of the family, so we have to also assess who it is providing the day-to-day care and what is the relationship with the patient. Now, insight about does the patient and the caregiver know about the diagnosis, the prognosis, and what palliative care is. Okay. Now, very quickly, why is it important for us to know to what extent the family and the caregiver, the family and the patient know about the diagnosis, the prognosis, and what palliative care is about? Anyone? So they can plan their priorities. Anyone else? Anybody else? No? Why do we need to know whether they know their diagnosis, prognosis, and palliative care? What palliative care is? They should be aware of what might come next to help them gear up and cope with their current situation, so they can be aware of what they're going through, to know what to expect out of the situation. Yeah. And also to orient ourselves as to how far we can go with them. Okay. Now, also please remember, someone might know their diagnosis. How many people in this room know what is the meaning of cancer of the buccal mucosa? What does that mean? Cancer of the buccal mucosa. Just yes or no. I don't want the whole definition, but how many people in this room know what it means? Cancer inside the cheek. Yeah. Okay, fine. Mr. Vishwanath, are you saying Mr. Vishwanathan? I think you're muted. Were you saying something? Still muted.
Sir, can you please unmute from your end and talk?
Okay.
There you are. All right. Yes.
Actually, because I think it is throat cancer.
Okay. So, see, there's varying levels of understanding in this room. This is in spite of the fact that I would say everyone in this room has a certain sort of involvement with healthcare or caregiving or whatever, right? So people who are caregivers, people who are patients, we very quickly pick up the language around the disease. Sarcoma, carcinoma, all of that. How many people know what those things mean? Knowing the diagnosis does not mean they know what it means. Okay, we pick up the words very quickly. Now, for example, my mother had idiopathic interstitial lung disease. I know the name. It took a doctor to sit down and tell me, you know what this means? It means that, okay, this is normally it would be like a coating, like a soap, like soapy water around the tiniest parts of the lungs. Then it hardens, it becomes like gel, then it becomes like cardboard, and eventually it becomes what we call honeycombing. And this is where the oxygen exchange becomes very difficult. So knowing idiopathic interstitial lung disease and knowing this are entirely different things. So if someone says they know the diagnosis, ask them to tell you what it means. Okay. Prognosis, where a lot of people don't know what the prognosis is, or know the prognosis but are in denial of it. I might know that it's a very serious condition. Have I accepted that it's a serious condition? Sure, I have. But every third day, I'm going to a new doctor. Have I accepted the prognosis? What is my behavior telling you? That I have not accepted the prognosis given to me by this doctor. I want another opinion and another opinion and another opinion till I hear something that is acceptable to me. Okay. And you will find that most people do not know what palliative care means and why they have been referred to a palliative care unit. And unless that is understood by them, it's very difficult to move on, because it'll come as a very unpleasant surprise to them later. So these kind of things you have to check before you go in. Where are we with you right now? Where are you in terms of your understanding of the disease, of the diagnosis, of the prognosis? And do you know what palliative care is and why you've been referred to it? Okay. All right. The next thing we need to know is family structure and dynamics. Now, in palliative care, the whole family is the unit of care. It's not just the patient. We look at the entire family as a unit of care. And in order to help them best and serve them best, we need to understand what makes them tick, who is in the family, how do they talk to one another, what is the relationship like. Now, some of you are familiar with this idea of a genogram, right? How many people here know and use genograms? Very quickly, just you can use emojis or show of hands. People have used, yeah, okay. I can see Saptik, Neha. Saliha, all right, great. Kavita. Yeah, so some of you here, and senior, I don't know, I'm thinking it's in the minority, yeah, the number of people who have used genograms.
Yes, ma'am.
Okay. A genogram to me is one of the easiest, coolest things to do because it saves me writing pages and pages and pages of notes. And it is a graphical representation. So some of you, the way you use genograms might be different. There are different ways to use it, but I'm just going to go through some of the basic ways. Now, it's a graphical it was created by someone called Murray Bowen. Graphical representation of a person's family over at least 3 generations, which tells us about the structure, dynamics, strengths, and resources of the family. And the types of information that you can capture in a genogram are name, age, educational, occupational, professional, profile, and emotional relationships. Typically, these are some of the most basic symbols: a square for male, a circle for female, 1 line for married, a line across for separated, 2 lines across. So you can actually just go online and see all the different symbols that there are. Okay, so also there are symbols for, adopted child, a foster child, pregnancy, stillbirth, whatever. So depending whether you're coming at it from a maternal and child health perspective or coming at it from another perspective, you'll find that there are many, 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 many ways in which you can describe different things. Now, also what is relevant to you in that context to put down. Now, you also put down emotional relationships between people by drawing these kind of lines between them. Yeah. So if there are always people in the family who are closer to one another than the others, there are people between whom there's a lot of emotional intimacy between spouses, siblings. It could be between certain cousins, but they're very, very close in terms of emotional intimacy. There are also obviously in every family hostile relationships. Sometimes there's violence. Sometimes there's emotional abuse, and this is information that you might get over a period of time. There might be sexual abuse. There might be neglect. Neglect is also a form of abuse, where a child or a person is not given the kind of attention, emotional nurturance that they need. Okay, and all of these aspects will tell us a lot. Now, also what happens is that, why would we need to know something like neglect? In the cases of pediatric palliative care, when one child is sick, very often the second child is not given as much attention because the sick child gets all the attention. And so that's one way of also showing that. Okay, now here is a genogram. I'd like one of you to please try and read it out, like read it to me, like try and interpret this genogram for me. Anybody?
Yeah, Kumaran is a male and Laila is a woman. Both are husband and wife, and they have a child, Shaji.
Yep.
And Mohan and Leela are husband and wife, and wife is a homemaker, and they have a Sindhu, a daughter. And Sheja and Sindhu got married, and they have 2 children, who studying 8th standard, Amal and Vimal. And Sindhu and Raju also have marriage. I am not sure how to interpret it.
Okay, so this
they
is
have a child.
Yes, please go ahead.
That's all, ma'am. Sindhu and Raju has a relation, and they have the child also.
Great. Okay. Now, typically, when you shade it, it means that this is the person in question, that the patient. The X marks someone who is deceased. In some cases, people mark the X as the person who is the patient, and they might shade out people who are deceased. It entirely depends on how your team uses it. Okay. So in this case, Sindhu is the patient. Now, this tells us structure. Okay, it tells us the structure of the family, it tells us who is in whose life. But then, of course, there are some gaps. There is some confusion. I know that some of you are confused about some parts of it. To me, this is not a complete genogram because it doesn't show any other siblings. Okay, so this is the actual genogram after we have a couple of conversations with Sindhu's family. Now, would someone like to tell me the story of this family? Anybody? Someone other than Dastagir? Just work your way down from the top. Okay, let me egg you on a bit. So same, Laila and Kumaran have a son called Shaji. Mohan and Leela have a daughter called Sindhu. But Mohan and Leela also have other children, Indu and Bindu. Sindhu is the middle sister. Both of these sisters are married. Kumaran and Leila also have an older son, Subhash. He's a plumber and he's married to a woman called Veena. Raju is somebody Sindhu used to be married to, but is now dead. And this is her second marriage. She's married to Shaji. And the circle tells us that all of them live together. These are the people who live together. Okay. And beyond that, we have some dynamics that we're seeing. We see that Sindhu is very close to both her sisters. There's a strong positive relationship between them. And Sindhu is also extremely close to her son from her first marriage. On the other hand, we see that Subhash and Veena do not get along with Shaji, and Shaji also does not, like, he has hostility towards the son from the first marriage. He is particularly close to, he's got a strong relationship with his twins, and Sindhu is also close to her mother. There is a friendship between the twins, one of the twins and Sharat. Okay. Now, doesn't this picture tell us a lot more? Doesn't this picture tell us a lot more? Now, if Sindhu is your patient in question and we are getting this sort of a family tree, we know now that who she counts on for support within the family. We know who cannot be relied on in terms of providing support to them. Yeah, we know that there are dynamics within the family that might get in the way of, like if Shaji does not like Sharat, then maybe there's something that we need to pay attention to over there. So the thing about putting a genogram like this together is that it is a much richer story of the family. We know who we can ask, who we can rely on within the family. We know who the confidants are. We know who talks to whom, who doesn't talk to whom, and where maybe sometimes financial assistance comes from, so on and so forth. So this is an important way. And every time you meet this patient, this is not a genogram that we were able to put together in just one sitting. This has probably been drawn over 3-4 sittings. And every sitting then tells us a little bit more about this family. Now, what this does for me as a clinician is that it gives me a snapshot of this family. And the more I practice this, just the art of using a genogram, the easier it is in terms of me saving time. I don't have to write one paragraph about, oh, Shaji does not get along with the other son, and he favors his own sons more, etc., etc. It's all just there. The important thing is that everyone on the team needs to be able to read the genogram the same way and use it the same way. Okay, so once the social worker has had a conversation with the family, she can add some stuff on. If the nurse has had a conversation and something else comes up, she can add some stuff on. So it's a tool that we use constantly and we keep going back to, no matter how long this person has been in our care. Okay, now relationships current status of relationships, of important relationships, are also part of psychosocial assessment. And that is what we're doing with the genogram, because it tells us who is supportive, who are the people estranged, who, if the patient is isolated emotionally or physically. And we know that relationships can get altered by illness. People who have not been speaking to one another for a long time may actually be facilitated to have a conversation again once they know that that there's a serious illness. Okay. Now, the next thing I want to introduce you to is an eco map. Okay. An eco map is basically tells us the support system that the family has around them. And it's something started by Anne Hartman. It's a pictorial representation of patient's family in its social environment and the family's relationship with the larger society. Okay. Genogram tells us the family members' relationship with themselves. This tells us the family's relationship with the larger society around them. And it's a snapshot view of the most important interactions of a patient's family with different systems group, extended family, individuals, organizations, associations, and so on. So this is what an eco map would look like. Who are some people might be religious, so they might have a very strong connection with the religious institution. Of course, there is the schools that the children go to, the health service that the family relies on, whether it's the attending doctor, the home care team, whoever, their extended families, that's all their cousins and uncles and aunts, friends, neighbors. If they were employed, then what is the relationship with the employer? Local services like the panchayat, like, various other things, women's groups and so on, clubs and other things. Now, this is what we do typically in a eco map. Again, we draw the family, just the immediate family, not the extended family, the immediate family within a circle. Here, we're not going into the genogram. If you want, you can, but it might complicate things. But here, we're just trying to see who has what kind of a relationship with the larger system. Now, for example, here, the whole family has a very strong bilateral relationship with the church. They're religious family. They go to church every week. They're very invested in the congregation. The congregation, therefore, also supports them to a large extent. I would see the church as a source of strength, comfort, community for this family. The lady, she is also part of a self-help group that also comes in to support her. The father has quite a strong relationship, positive relationship with his colleagues at work. The public health center does not really, provide that much care. It's a weak sort of relationship. And similarly for the local panchayat members. Now, this family's had trouble with their water and infrastructure, but when they approach the panchayat has not been very supportive. And the neighbors and this family don't get along. The neighbors are hostile towards this family for whatever reason. Volunteer comes in and checks on all of them. The son, to him, his college is a place that he is really, really strongly attached to. And for both of them, their friends are really important for both the children. And this girl here, the school is a place that she has a positive relationship with, and she's part of a youth organization. Now, I've sort of deciphered this eco map to you. You as healthcare providers, volunteers, etc., what would you do with this information? Say that this is the family that you're taking care of. This is the 55-year-old woman who is not well. She has come to you from the RCC in pain. The husband and the son have accompanied her. The daughter has not. Okay, this is the lady with the buccal mucosa. Knowing this information, what clues do you now have on how you can help her?
By knowing their relationship with other members in the family, we can take their help in their emotional support. And in case of emergency, we can let some organization to take care of them before the actual care reaches them. And and we can ask some of their colleagues to interact with them as and when required, so that they can take some social interaction and they feel socialized. That way we can take.
That's a good point. What role can we play in strengthening their relationship with those that are weak? The relationships that are weak. Any social workers here in the audience? What would you do? What are some of the ways in which a multidisciplinary team can engage? The church may be used as a point of intervention. Absolutely. Yeah. Sensitize the panchayat members and the public health care. Yeah, that's the answer I was also looking for, Shiv Kumar. Yeah, bring in the church. Yeah. So now here's the thing. As a social worker on my team, we can go across and have a word with the panchayat, let the panchayat know that, see, this is a family that has some serious illness and they could really use your support in. And so that sort of a, facilitation process can come in. We make sure that the children do not lose contact with their friends, because that's a really important source of, and being in a household that is tense and sad all the time is very, very bad for a child's mental health. So we make sure that those connections stay strong. And that youth organization and so on. Find a way to improve relationship with the neighbors. Exactly. Because you know what, when you're in need, if your neighbors are not on your side, that's very, very difficult. So how do we do that? Okay, so I think we all get the sense of how and why these genograms and ecomaps can be useful. And really it gives us a map of the territory and says, okay, here's some place where and see what happens is, if you've gone and spoken to the panchayat member, they've become more cooperative, then this line changes. You can change this line to a much stronger line. And so now you know that this has happened. Inform the school and friends to be more supportive. Truly, yes, that's great, because very often when an educational institution, the teachers, the friends need to be told that, how they can support people who are experiencing serious illness back home, and that can go a really long way in providing them that sort of support. Okay, and finally, within the family, I think we are all, because people here I know are sensitive to this. The caregiver is such an important person, the primary caregiver. And this is a quote by Rosalind Carter. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. Okay. And for us, it is really, really important that we acknowledge their complex roles, because caregivers they have a ringside seat to all the suffering. They're doing all the heavy lifting in terms of direct and indirect care. Direct care is what you do to a patient, give them a bath, feed them, etc. Indirect care is what you do for them. They go to the bank, get their, get errands done for them, so on and so forth. And that caregiver is really, really somebody who is facing burnout, but especially in some of our cultures, we don't allow caregivers to speak up and to complain. We say caregiving is a duty and it's a service, it's a sacred act, but that doesn't take away from the fact that it's one of the most difficult roles in the world. And sometimes a caregiver might have their own experiences of feeling angry or feeling sad, and they should be given that space to express those difficult negative emotions. We will talk a little bit more about that in another session. And so acknowledge their complex role, elicit their concerns, and provide support in ways that are most appropriate. I want to just spend 1 minute on this word, bystander. It is my personal least liked word in healthcare, because the word bystander, what is the definition of the word bystander? It means somebody who's standing by. Yeah. And is that what a caregiver does? A caregiver is the last person who's standing by. They are, like I said, they are doing all the heavy lifting. And somehow this word seems to have come into our health services, the bystander. It is a demeaning word. And I request everyone present here today to please remove that word from your vocabulary when you are referring to somebody who is taking care of another human being, because it's, they have a name, and it would be really, really, it's a human, this is one way of showing respect. This is one way of showing empathy and compassion. Ask them their name, refer to them by their name, understand the relationship. And exactly, yeah, bystander is someone who just stands by, takes videos, and doesn't do anything to help. There couldn't be a more inappropriate term for a caregiver, in my opinion. So if there's one thing you take away from this session, please let it be this. Do not call people bystanders anymore, even if the hospital is calling them that. Learn their name, learn who they are. It will really, that is one of the most fantastic ways in which you can build rapport with another human being. Yeah, ask them their name. Okay, so so that's one thing that I will request from everybody. Okay, so moving on. We've talked about the family, the dynamics, the structure, etc., etc. Socioeconomic condition. Do they have adequate food, clothing, shelter? Who is the breadwinner and who controls the finances? Okay, now, who controls the finances? Is it always the breadwinner who controls the finances? No, not always. The other thing is, please remember that the caregiver may not have any financial control over the interventions, right? The person who controls the finances determines the treatment trajectory. Please remember, please try and, let's just spend a minute on this. The person who controls the finances is the person who is the most, probably the most important decision maker in the family. That person may not be even living in the house with the patient and the caregiver. It might be somebody who is living abroad, earning and sending money back home. And even though they are not involved in the day-to-day support and care of the patient, they get to decide where the money will be spent. So this is an important point. Okay, so who is the breadwinner, who controls the finances, and who is the decision maker based on who controls the finances? And understand this, because you might go to the caregiver and say, this is what needs to be done, this is the best way to do it, etc., etc. They will come back to you 1 month later, it's not been done. We cannot get irritated with the caregiver because I gave you explicit ways in which we can set these goals and do this, but you've not done it. They may not have done it because they don't control the finances and therefore don't have the capability to make some of those decisions. Okay. Yeah, and the person who controls that has the last say. Okay, Saliha, ma'am, is it necessary for the patient to know their diagnosis? Because lots of caregivers don't want. Yeah, that's collusion. We will be talking specifically about collusion in the communications module. And I'll be spending a lot more time on that there. We're going to be talking about breaking bad news, collusion, decision making, and so on. That'll be happening in the communication section. Okay. All right. Source of income. What debts does the family have? What? How far? How far in debt are they? Social support, government schemes, local financial support. What are the schemes that they're eligible for? What have they made use of? What have they not made use of? What do they not know about? Link them to those last mile sort of subsidies that governments have in place, which differ from state to state. And what is the status of the education on the children? Are they struggling with that? And I know that not everybody runs an education support program for the children, but find one in your area perhaps that might be able to help. And see, now when I do a home visit, that also tells me a lot about the socioeconomic condition, right? Here is, this is one home care visit. It looks like a straight road. Actually, it's not. I'm standing on top of a hill, and this is actually a slope. It's a pretty sharp slope down. And then it becomes this, it's all rocks, and then it becomes mud. And then there's one stream here that has to be crossed. And in the rainy season, this is a very slippery sort of place. I go to the person's house and I find that this is their living condition. The monsoon is about to come. They just have some tarp on the roof. They're sleeping in a room where the chula is in the next room. So if there's any cooking happening, the smoke there. So these are some of the things that you'll see that might be what is causing some of the symptoms to be exacerbated and stuff. So here, there's no point me giving medication for various things if through the monsoon that roof is going to be just leaking all over them. Can I speak to the panchayat people? Can I speak to some sort of group in the area and just at least get this roof sorted out so that that's one problem that these people don't have to face? Yeah. I can't ask this person to come for physiotherapy and stuff like that when this is the road that they have to traverse to come to me. So a home visit, if possible, is usually a great way to get a very, very, detailed perspective of what kind of life people are living. Psychological assessment requires us assessing them for distress. What are their emotional support needs? We will talk about this in a session on mental health specifically, which I will take you through. What are the different tools to do that? So I'm not spending too much time here because it's a vast subject, but we will talk about how do you assess somebody's distress? How do you assess their emotional support needs? How do you understand what their coping mechanisms are, how healthy those coping mechanisms are, and how unhealthy they are, and what are some of the risk factors that the family is exposed to, risk factors in terms of what might cause, say, for example, suicidal ideation or various other things. So this aspect we will cover specifically in the mental health interventions session, which is in a couple of weeks. Okay, spiritual assessment. I want you to please look at this we'll send it as part of the learning material. Senior, please make a note of it. The Oxford spiritual assessment tool. And I find that particularly useful because it helps me assess patients along 4 verticals: connection, strengths and comfort, hope, concerns, and the 4th is meaning, which I have not included here. Now, spirituality, like we talked about in our first session, is not only restricted to religious faith, but it has meaning, purpose, hope, concerns, and various other aspects that really make a person feel alive, feel like they are connected to a larger fabric of the universe or to their society, communities, that they're meaningfully contributing, that there's a purpose for their lives, and so on. And that particular tool, I will share it with you. It's very self-explanatory. The thing about using that spiritual assessment tool is it's not a checklist. You need to work it into your conversations with people. And the beauty of using a spiritual assessment tool like that is that it reframes certain aspects. Like, for example, a lot of people might be focusing on the negatives, but the spiritual assessment tool will have questions like, tell me, who do you look to in times of distress as someone who provides you support and comfort? And I'm sort of nudging the person to actually look at those aspects. Where do you find your strength in moments of crisis? How did you overcome crises previously in your life? Where did you look to support then? So I'm reminding them gently of places where their strengths and resources might be. So we will send you the link to that. Take a look at it and see how you can work it into your practice. And if you have questions about it, I'm happy to answer them. We can take that offline. Yeah. And finally, this is a section that a lot of people find very uncomfortable. How do you assess psychosexual well-being? We have a lot of patients in our care who've been through our rehabilitative services and something called the halfway home. And a lot of these are very young people who have either been in a road accident or, they've had an accident like toddy tapping and falling out of a tree or whatever. So these are spinal cord trauma patients. And some of them are just married, 2 months into getting married. This has happened. Young bride, arranged marriage, and now they are here. So, of course, I mean, on the surface, we can talk about various things. But here is a woman who has married this man, probably has lots of hopes and dreams and aspirations and intimacy needs. And now he is wheelchair bound, and all the focus is on that. Similarly for a young man, how much distress do you think this aspect of their relationship is going to be causing them? This lack of sexual intimacy, or the ability to have sexual intimacy as a result of illness, disease, injury. So how important is that in these two people's lives? Not just the patient, also the caregiver.
Maybe dissatisfied life they may feel, and they may lose hope, so it may not go away.
Yeah.
So do I have to stay with this as a long run?
There are two things that I think many people hesitate to talk about. It's death and sex. Probably the two most unavoidable aspects of most people's lives, right? So, but these two things we don't talk about. And if you think about it in the way that there's so much taboo and stigma around it, you might think that we're a country of 1 billion immaculately conceived immortals. But we need to talk about this, because it's only when we talk about it that we can make it easier for other people to talk about. Now, it's not just the sexual intimacy, it's also the fact that, having children, and so many different aspects of sexual intimacy are important here. And if nobody is talking to them about what it means to have this taken away from you, then where is that distress going to go? We have seen lots of cases where, it's a young man, he's wheelchair bound, the woman is running around taking care of everything, and she steps out to buy the groceries. She's also probably trying to get a job, etc. And I can tell you from my experience in palliative care that there is a significant number of those young men who are wheelchair bound who are suspicious of their wives, or think that they are looking elsewhere to have their intimacy needs met. And there's a lot of distrust in that family. So because nobody has actually sat down and had these conversations in a lot of, and there are ways in which that intimacy can be developed, it can be facilitated, but unless somebody talks to them about it, it's not going to happen. Yeah. For that, we as providers have to also remove the shame and the taboo and the stigma around it. And we have to educate ourselves. And I would say that this is a big challenge in today's day and age, because how many people even talk about sexual health openly in a way that can be useful in palliative care settings? Yeah. So I would say that this is our responsibility as well. And it is sometimes, it just takes a little bit of a nudge for maybe someone from, especially if it's a very sort of conservative family, someone from the same gender, to go and have a conversation. And immediately you'll find that there's a lot of stuff that's held in, that's being spoken about. So even to be able to talk about it is your first step in providing that support. So please don't miss this aspect of supporting somebody when you are talking to them about what it is that is distressing them, because if they are not asked about it, they are not likely to talk about it. Yeah. There you go. Yeah. So I can see a lot of thoughts and reflections in the chat box. Thank you for those. Okay, so coming back to sharing my screen. So once you have all of this information about family dynamics, who stands where in the family, what is the socioeconomic status, psychological state, spiritual and psychosexual, then we have the information. Okay, we have a starting point. We know who to liaison with. Should we liaison with the church? Should we liaison with that youth group? Should we talk to the sisters? and we can provide supportive counseling to the people who are identified as vulnerable within the family. It might be that second child who no one is talking to because they think she's too young. So maybe she's the one who needs the supportive counseling because she's invisible in the family. Facilitation with maybe, with the self-government bodies, with other volunteer support groups, etc. Rehabilitation, whether it's vocational, whether it is physical, and if later required bereavement support, which I will talk to you in another session about. And what is important here is regular follow-ups to make sure that that genogram, that eco map, and all those notes that you're taking are constantly updated, because assessment is an ongoing process, like we said, and it changes with the trajectory of the illness. And so to summarize, assessment is the essence or a working hypothesis. So you are not arriving at a conclusive assessment. It will keep changing. It is a participatory process. It requires you to, to walk in with curiosity and really allow people to tell you their story, the patient, the caregivers, other people in their families, other people in their lives. And information can be derived from different sources. Proper assessment helps us to identify the exact impact of the illness along the different domains, what is available to the patient as resources and strengths, what are the power dynamics within the family, and how we can work around them and use them as strengths rather than have them as barriers. And one very, very important thing is all assessments have to be documented, revised, and updated. We have to be as scientific as medical professionals are, and also it allows us to then see how much, where we are, what interventions are working, are not working, where we need to tweak and pivot our own approach to things. So I'm going to stop with that, and we have 10 minutes. So does anyone have any questions or would like to reflect on something that came up for you today, or maybe share a story you were able to provide an effective intervention in a psychosocial setting? Please, it's open floor now. Feel free to unmute your mics.
Am I audible?
Yes, please go on.
Ma'am, so not sure if this question is related to what the session was today. So I've recently joined as a counselor in Romila Palliative Care, Mumbai. I come from a social worker's background, and there's this one difficulty that I find, because I have patients in slum areas. I mostly work in Dharavi, Govandi kind of regions, and those are patients who are actually, to be honest, very much illiterate and do not have an understanding of what kind of situation they are in. So as a counselor, I'm not a trained counselor though, but being a beginner, it becomes very hard for me to initiate a conversation with them. So could you actually guide me, or will there be a session that will actually help me out?
That's actually, thank you for sharing that scenario. It's less uncommon than you would imagine. Yes, we do have a session on communication. So I'll be happy to go into it in more detail there. Having said that, you're saying that you have difficulty initiating conversation with them, is it? I mean, and what is the resistance that you're finding, or where exactly do you feel you're getting stuck there?
Okay, so the first thing is when we walk in as a team. So it's the doctor, nurse, and the counselor walking in for the first visit. And when I am introduced as a counselor, the first thing that by default comes into their mind is, do I have a psycho problem or something? So eventually they do not call me back. So either if I am the person calling them upfront, they'll either cut my call or they don't want me to visit. This is what's happening. So there are few cases. So currently I am actually taking bereavement cases and all, but still there are patients that I actually feel that they do need support, because that's my first observation. But I'm not able to maybe just even building up trust, I need to initiate a conversation with them and start telling them ki, I am here not just to just sit and talk, but also I want to be a good support for you. So that eventually this entire palliative care can go in a very smooth process. So that is also being very hard for me. So just wanted to.
Okay, so I find it amazing that people in Dharavi they know what a psychologist's role, the myth about mental health has reached Dharavi, and that they would imagine that, this is a stigmatized thing to talk to a counselor. I find it absolutely fascinating in a way that that much, the myth has trickled so far in. And so my first question is, how important is the designation? Okay.
Yes, yes.
Okay. How important is the designation? Why is there a possibility that maybe that you could be introduced to them just by a member of my team and your name? Yeah.
Yes.
That's one question that is possible. I mean, that's one way that's possible. The second is to actually name it and say, I sense that there's a lot of discomfort around this idea of a counselor being part of the team, but please, that's a great way to actually bust the myth and say, our job is not to only help people who are quote unquote crazy or mad, but really to just provide support, not just to you, to also to my team members, to help them understand your situation better. So it is actually an opportunity to bust that myth, but you have to name it. Like in suicide prevention, in suicide risk assessment, I don't know if some of you have experience with it. We actually call it out and say, do you feel like you're in a place that you want to end your life? A lot of people say that, oh, by saying that, you're putting that idea in their head. You're not. If that idea is there, they feel actually seen and heard when someone says that to them. I mean, it has to be done with tact, of course. But I would say that very often discomfort in a scenario should not be crept around, but it should be brought and placed in the middle and said, tell me what about this makes you uncomfortable. So we can have a conversation about that separately, Prince, and but we will be covering aspects of it in the communications module. But I would also, we are, all of us are quite, we have a certain way of working, but I would say just check with the rest of your team how important introducing you by that designation is.
Okay, sure.
You can, I mean, it's not that you want to hide what you do, but at least it's not presenting an immediate barrier right up front. Yeah, at least they're getting to know you. You sound like somebody who's quite empathetic and compassionate. I'm sure after one conversation with you, things will get a little easier. Yes, Anup.
Yeah, so one of the scenario we discussed today, like in patient confidentiality, we have to, if the patient is HIV positive, we have to inform the wife. In the same scenario, take an example of 22-year-old who's on wheelchair, maybe he got a chronic disease, who's going to die. So the person may be thinking of making baby and someone who can carry forward his legacy. But if you see the female, anyhow, if she come to you and she asks, should I have a baby or not? So how will think about in such situation? I am treating a patient and I should be think in way of patient, or I'm treating the family. Because both ways, if I'll do the right statement to the wife, then the husband don't like it, or maybe he's my patient. So this is some of the contradictory situations came into my mind. How we can come out from this situation?
So India, autonomy is a very Western concept. Autonomy is my right to determine what is good for me and what I want. In countries like India and several other places, we tend to follow a more collective autonomy. Autonomy is interdependent with the people we live with and people in our lives. So that we have, and what you've just pointed out is a very, very, it is that complex web of, breaking somebody's trust. Now, firstly, something like this, can I have a child or not? I think she has a right to know. She has a right to know that.
Yeah.
But I would also first assess where the whole family is at, and whether they have accepted that because it is very delicate. I don't have, unless I know the details of a case like this, I wouldn't even be able to know, like, unless I have the genogram and this, who can I rely on? Can I talk to one of the elders in the family and ask for their guidance? Help, this is happening in your family. How do you think is an appropriate way to handle this, rather than me as an outsider coming and delivering news that is so devastating to the family, right? Surely the elders would know about something, or someone else in the family might be taken into confidence. So I don't have an answer for you, Anup. It's a difficult one because collusion comes in different ways. So I'm going to make a note of it. Let me just do some research, and maybe in the communications section, I'll try and come back to you with a little bit more information about this.
Sure, that will be very helpful. Thank you.
Thank you.
Ma'am, we have a few questions in the chat box.
I can see the chat box is busy. Who will be the one responsible for starting this sexual well-being, for example, if we happen to visit a paraplegic? Yes, so I think, Abhilash, you've answered your question. The question that you've asked, you seem to have answered it yourself. Yes, we have to initiate the conversation amongst the husband and wife as early as possible. How are such problems being handled in general? They're not being handled very well at all. They're not. In most cases, forget sexual health in that sense. Unless you're in a gynecologist's office or in reproductive health circles, I don't think these sort of questions are being handled. So do I have a template for you? I do not. But but I would say that you have to be mindful of what is acceptable in that family culturally. Like, maybe it has to be an older woman talking to the woman first. It has to be a man talking to the man first, then getting them to agree to have a, because even with like young couples or even older couples, having a three-way conversation about sexual intimacy is not comfortable at all, right? So maybe you need to prep them a little bit to say, maybe this is a conversation we need to have together. And how would you be okay? Like, we'll make sure that it's safe, it's confidential, and it needs facilitation sometimes. So it would, again, really depend family to family. Couple where his wife met a man. Okay. Oh gosh. Okay, that's a terrible incident, Shiv Kumar. How then and best can the other stakeholders involved in the society be helping such individuals? Okay. That's a pretty heavy question for 429. But I will try and answer it. See, even the language that we use, sometimes, guilty of not providing him marital bliss. And this is, I know that these are not your words also, like this is the kind of expectation that society places on women. It's your duty to go and provide this XYZ. In a family, these are the role definitions and so on and so forth. But the fact that happened really speaks to a lack of empathy in our culture in that sense. So maybe, I don't know, it starts with having more open conversations about, as soon as the accident happens, or like as soon as we have some sort of prognosis, there has to be some sort of family meeting where this information is shared in an empathetic way, where we talk about, what is the impact on the family's long-term expectations, because surely this is not the way, this is the worst way it could have gone. So again, I think family meetings are really important. And in that sense, no, I know it's not your words. But what I'm saying is that we sometimes feel that psychological counseling is the domain of only counselors and therapists. Doctors don't have to do anything about it. But very often, the family will listen to the doctor because they see them as an authoritative figure. So how about we upskill ourselves in having those conversations, right? Like Prince was saying, the minute somebody hears that he's a counselor, they don't want to talk to him. So while it's important for us to have a multidisciplinary approach, in palliative care, we call it interdisciplinary, because it's not multiple disciplines, but we intersect with one another. every single person on the team has to have the ability to communicate bad news, or to be able to provide that sort of supportive conversation. And like I said, sometimes it has to come from a medical person, right? Who is seen even now as probably higher up in the hierarchy than somebody who is a non-medical person. So again, not a very conclusive answer to your question, but this is really, it speaks to the state of our issues in society today, that we're still having conversations like these. But I'm glad that we're all thinking about it. So at least I'd like to thank you for putting those on the table. I'm certainly taking notes, and I will try as far as possible to incorporate as many of your points into our communication section. So I think we're at the end of the hour. Senior.
Ma'am?
Yeah.
Ma'am, I want to add something actually to what Prince had said. So one thing we also face, initially what I used to face being a psychologist here was, they used to be like, yeah, I mean, we just heard about a diagnosis. The next thing is not, this is not what we want. But a lot of the times what worked for us was that we would introduce ourselves as, I work with so-and-so doctor, and just that. And, just testing the grounds and seeing how receptive they are of, having one of us come around, and seeing, and then slowly breaking the news that, this is who I am. Like, I'm a psychologist here. We just come in to make sure everything is okay, and just to keep the child company, because I primarily work with pediatrics. So just to keep the child, just give the child some company and things like that. But what we've noticed is that they are very receptive. Like post that, they get very receptive, that they're like, yeah, we're glad that you guys are here, because they understand how important it is. Because initially they may not be okay if we would have told them that, this is who we are, this is what we do. But just testing the grounds, not just something the patients would do to see how much can we open up to you, but that is also something what we can do to see how much, how receptive they are going to be to what we say.
Thank you. Thanks, Neha. That's very helpful. And I think we're in agreement that maybe that's the way to do it. It's not deception. It's also really just treading lightly around other people's assumptions, and then slowly building that rapport, winning their trust, and then actually, coming, when they feel safe with you, they start feeling safe with the entire concept of mental health support. So thank you very much for that. And thank you everybody for being so interactive. I really appreciate it, and see you next time. So take care. Thanks, Senia.
Thank you so much, ma'am, for that elaborative session. Thank you so much. Thank you all for joining. I do understand that some of you have some confusions regarding learning materials. Actually, all those learning materials are uploaded in the LMS IECO platform. You can fetch it directly from your own account. I'll be sharing a small video regarding on the same thing. Thank you all. We'll see you on the next session on 1st September with pain and its impact. Bye-bye.